My name is Julianne. I'm the Research and Programs Coordinator here at the Banff Sport Medicine Foundation. So we're primarily a research and education foundation, and we work very closely with the Banff Sport Medicine Clinic. Joining us tonight is Dr. Alexis Rousseau-Saine. He's the current Banff Sport Medicine Fellow, who'll be here with us until the end of June, and then he'll be going back to Montreal to start his own knee practice, and he'll be sadly missed. So just sort of a couple of fun facts about Alexis here. He was a former amateur CIS football player. I think hopefully I got that right. And he now enjoys hiking, skiing, fly fishing and hunting. So thank you everyone for joining us. And just a little bit of housekeeping before I hand it over to Alexis. What we're going to do tonight is, if you have questions, we're going to have a Q&A time at the end of the talk. But certainly if you want to sort of pop things in the chat as they come to you so you don't forget, go ahead and do that. I'll monitor the chat at the end and make sure we cover any questions that we haven't covered. Otherwise, certainly feel free at that Q&A at the end to unmute yourself and ask any questions that you might have. Okay, so with that, I'm going to mute myself and then hand it over to Alexis.
Thanks, Julianne, for the introduction. Thanks, everyone, for joining. Thanks to the Banff Sports Medicine Foundation for the opportunity to present this webinar on meniscal allograft transplant. I think it's going to be a really interesting subject, whether you are working in physio, in general practitioner, or in sports medicine. This talk has been tailored kind of to be a summary of what we do here at Banff Sports Medicine for meniscal transplant. So I hope everyone will enjoy the talk, and we'll have plenty of time at the end. Feel free to ask some questions. It would be nice to have some discussion at the end. So here we are. Let's see what's on the menu tonight. So we'll do a basic review of anatomy and roles of menisci. Then we'll define what is a meniscal deficient knee and how can we identify those patients in clinic. Then we'll discuss more about what is a meniscal allograft transplant, or M.A.T, who is a good candidate for that type of surgery. And then we'll go over the surgical steps, and then the different phases of rehab, and then we'll talk about briefly about results and the program that we have set up at Banff Sports Medicine. So I hope you guys will enjoy. So let's talk about the anatomy of the meniscus. Meniscus is between the femur and the tibia and the knee, and is referred as a fibrocartilage. So it's similar in its composition to articular cartilage, but the cells in it, even if there are really few, are referred as fibrochondroblasts. So they're similar to chondroblasts, but slightly different. And you can see that a meniscus is mostly water. It's 72% of water, 22% of type 1 collagen, and the rest is extracellular matrix with glycoaminoglycans, which actually retains water. And you can see that actually the percentage of DNA, so of cells in the meniscus, is very, very low. So it's mostly an acellular structure. It's also a poorly vascularized structure. So if you look at that microscopy picture at the bottom, you can see that the blood vessel only penetrate up to the first third of the meniscus, the peripheral third, and the rest of the meniscus really doesn't receive any blood supply. So that has an implication in which some type of meniscal tear don't have a potential of healing, and that's why sometimes we have to perform meniscectomies and leave patient without most of their meniscus. So if we look at the shape, the medial meniscus on the left-hand side of the diagram is more open C-shape, whereas the lateral one is more closed, more of a U-shape. And we refer as a different part of the meniscus as the anterior horn in front, the body of the meniscus, and then the posterior horn in the back. Circled in red are the 4 roots. So each meniscus has an anterior and a posterior root. And these are very, very important because they attach the meniscus to the tibial plateau and they provide the stability to the meniscus, and they will be somewhat important when we perform a meniscal transplant. So we'll talk about that later. Let's talk about the roles of menisci. The first one is load distribution. So if you look at the MRI picture, you can see that we have a convex femoral condyle and a somewhat convex or flat tibial plateau. And the meniscus matches these two shapes so that it increases the contact area, it decreases the contact pressure. And you can see on the left picture that on the lateral side, it's even more important because the lateral plateau is a bit convex as well. So it's responsible for 70% of the load distribution on the lateral meniscus and about 50% for the medial compartment, for the lateral and medial compartment. We often refer to the meniscus as a shock absorber, and this is absolutely right. So when the knee is loaded, there is axial load on the meniscus, and the meniscus wants to be pushed out of the knee. So it resists this axial and outside force by transferring the load to the periphery and back to the root. So we call that the hoop stress, and the meniscus role is to dissipate and resist that hoop stress, and this is fundamental in doing its job as a shock absorber. One of the third role that is a bit less known is that it acts as a secondary stabilizer to the ACL. So mostly in the ACL deficient or ACL lax knee, the posterior roots, mainly of the medial meniscus, will resist that anterior translation of the tibia. So if someone has some ACL laxity, the posterior horn and root of the medial and lateral meniscus will see more strain, and they will contribute to the stability of the knee. Two of other kind of secondary roles are of proprioception through nerve ending at the periphery of the meniscus, and as well as lubrification through the few cells that are in the meniscus. So in summary, these are all good reasons to save the meniscus. And in the past 30 years of orthopedics, there's really surgeons are really more conscious of the function of the meniscus. We used to think that it was a vestigial structure, it had no role. We now know that it has a significant role in preventing osteoarthritis, and we save the meniscus as much as we can, meaning that we aim to have a stable knee to prevent further injury of the menisci, and we try to repair them as much as possible, or at least resect as less as possible. And we know that because people who have had subtotal or total meniscectomies in the past are doomed to have arthritis in their knee. And this is a patient on the first picture about 7 years after a subtotal meniscectomy. The second picture is at 10 years, and the last picture is at 13 years. So you can see that there is progressive osteoarthritis. However, sometimes we are not able to save the meniscus for different reasons. And the main reason is that sometimes these tears are simply not repairable, whether because it's because of the location, because of the chronicity, because of the quality of the tissue of the meniscus, and sometimes it is judged non-repairable. So here on the left picture, you can see a large bucket handle, so a displaced medial meniscus that is displaced in the notch. This one looks repairable, but sometimes it isn't, and you can picture that if this whole piece of meniscus is removed, there is not much left in the knee. We would see that on the MRI. So if we look at that sagittal cut of a MRI of the medial compartment, there are supposed to be two black triangular structures in the front and the back, and these are mostly absent. So this is a meniscus deficient knee. Another way to have a meniscus deficient knee is if you have a meniscal extrusion. So we were talking about the hoop stress. So if the meniscus is extruded from the compartment, it can't resist hoop stress anymore. And this is mostly due to either a root tear, so at the attachment of the meniscus, or if there is a radial tear, which is kind of similar to a root tear where the meniscus is torn through and through and now can get pushed out of the compartment and basically not able to do its job anymore. Usually we try to repair these type of tear, but sometimes they're not repairable because the meniscus has been chronically extruded from the knee or because the repair has failed. Clinically, how do we identify a meniscal deficient knee or a meniscal deficient patient? Well, a patient will describe really a localized pain in the affected compartment, whether it's medial or lateral, but it shouldn't be a diffuse pain, shouldn't be a pain in the anterior or patellofemoral compartment, should really be localized in the compartment and associated with activities. The more they are loading the knee, the more they are loading the compartment, the more the knee is reacting and giving symptoms. Same thing for swelling. People will tell that they have recurrent swelling, and it's mostly related to the volume of activities. They are able to walk 15 minutes. If they try to walk more, next day they will have swelling. So this is pretty typical. Sometimes, I would say rarely, the main symptom will be instability. So if, let's say, someone has a reconstructed ACL with a mild residual laxity, has a bucket handle that is removed, judged non-repairable, and then most of the medial meniscus is removed, they might feel their knee more loose afterwards because that meniscus was contributing to some stability. And in some cases, instability can be a sign of meniscal deficiency. So now let's talk about meniscal allograft transplant. What are the goals of surgery? The first one, and it correlates with the meniscal function, is to restore that function, obviously. So to restore the knee biomechanics by normalizing the contact pressures in the compartment and normalizing the contact area. And we know for a fact with biomechanical studies, with animal studies, with in vivo studies, that meniscal transplant do succeed at restoring the normal or close to normal knee biomechanics. Second goal of the surgery is to obviously treat our patient, alleviate the symptoms associated with meniscal deficiency, whether it's pain, swelling, or instability. And we also know by what we can see in the literature that there is a significant improvement of the patient's symptoms and reported outcomes. It's rarely excellent results where people feel like they have a total normal knee, but there is a significant improvement from preoperative to postoperative. And the last goal, which is more of the long-term goal and that we all believe in, is that the meniscal transplant will have a chondroprotection, a chondroprotective effect, and in the future prevent osteoarthritis of the knee. And I've put that one in italic because it is yet to be proven that meniscal transplant prevent osteoarthritis. We have evidence from different biomechanical, animal, and in vivo study. However, in the real world, it is very hard to do these long-term natural history study where we follow patient who had meniscal transplant and patient who did not, and see in 15 years who has osteoarthritis. Those are lengthy, costly to do, but it's something that the orthopedic community believes in, and we have more and more evidence to that leading and suggesting that we are preventing osteoarthritis if it's done in the right patient and the right way. So let's talk a bit about history. In the history of orthopedics, this is a fairly new surgery, first described in 1987 first results reported by a German group in 1989. And since then, this procedure has taken off mostly in Europe. And in the last 10 to 15 years, it has come more mainstream also in North America. However, when we say mainstream, it remains a rare procedure. It is estimated that it is only performed in 1 in every million people of population every year. So that would mean that in Canada every year, there would only be about 30 to 35 meniscal transplants, which seems about right, knowing how many centers are doing these types of surgery. Also important to say that it's no longer considered an experimental surgery. It doesn't have to be performed under a research protocol, but it's only a few centers and surgeons that have the expertise to perform this procedure. So where do we get the graft from? What do we put in the patient? So it's actually tissue that is harvested from deceased young adults, just like we would do for organ transplantation. The donors are screened for multiple blood-transmitted viruses and bacteria, such as HIV, hepatitis, and syphilis. However, since this is a very acellular and avascular structure, there is a very, very, very low risk, almost inexistent risk of disease transmission. For the same reason, the meniscus being avascular and acellular, there is no need for ABO matching between the donor and the recipient, and there's no anti-rejection medication, just like we see in organ transplant. So that makes things a lot more easier for us and for the patients, obviously. Types of graft, this is a bit technical, but just for general information, there are different types of grafts available, actually different types of graft preservation available. Most of the centers have moved away from the freeze-dried and the irradiated graft because they were leading to inferior results. And most centers now use freshly frozen allograft. So the grafts are harvested from the donor. They are cryopreserved, so frozen at minus 70 to 80 degrees, and they can stay in the freezer for about 2 to 3 years before expiring. So that gives us lots of time to perform surgery. The fresh graft have to be transplanted within 3 or 4 weeks of the donor's death, and studies haven't showed a real advantage of transplanting fresh allografts, so most centers now use frozen allografts. The only match that we do between the donor and the recipient is actually the size, because you can imagine that a 5'2" small woman patient versus a 6'5", 250 pounds male don't have the same size of bones and knees and meniscus. So we size match them, and we use these templating X-ray where we put a sizing sphere, and then we measure the length and the width of their compartment and compare it to the donor size. We are lucky in Alberta to have 2 provincially funded, government-funded tissue banks. So there's one in Calgary, there's one in Edmonton, and they really provide us high-quality grafts for meniscus, but also for tendons that we use for ACL reconstruction. And as this is government funded, it's not an increased cost for the hospital. So that makes the graft more available for us to perform the surgery, whereas in different provinces or in the United States, the centers have to pay for the graft, which is a limit of how many surgeries they can perform. So let's talk about who would be the ideal candidate for this type of surgery. Ideally young. We typically say less than 40 years of age. And this is not a strict cutoff. Some center would go until 45, until 50, and it all depends on the state of the knee. How is the overall health of the patients, but ideally less than 40. Also, same thing for the BMI. We'd like to have someone as healthy and fit as possible. The cutoff of 30, some people would go to 35, but we know that in the higher BMI, there is more pressure in the compartment, there's more meniscal extrusion, and the results are inferior. The ideal candidate obviously has to have a symptomatic meniscus deficient knee who has failed conservative management. And I think that's really important. It's not because we do a subtotal meniscectomy that we right away book a patient for a meniscal transplant. They go through rehab, physiotherapy to help strength, to help balance. This is really helpful. Activity modification is actually very important because some people at the point in their life, if they had multiple knee surgeries, multiple injuries, sometimes just modification of their expectations of the activities they do, less impact, less pivoting, and sometimes even if they have a meniscus deficient knee, they're able to live a healthy lifestyle and won't need surgery. We also can use unloader brace to unload the pressure from either the medial or the lateral compartment. And we can use also different types of injections, cortisone, hyaluronic acid, platelet-rich plasma, to just help the patient's symptoms, make the knee a bit more happy and healthier. And sometimes this will be enough to manage the patient's symptoms. Three other criteria to be a good candidate: having no osteoarthritis or no severe osteoarthritis. We can tolerate chondromalacia up to a grade 1 or 2, but more than that, we're past the window where we hope to relieve the patient's symptoms and slow the progress or stop the progress of osteoarthritis. Alignment is very important. If someone has a deficient lateral meniscus and has a significant valgus alignment, even if we put in a new meniscus in the compartment will be overloaded and the meniscus will see too much load and likely will be extruded and will fail in the early phase. This is not an absolute contraindication. It's just something that we have to address either at the same time as we do the transplant or in a staged fashion by performing an osteotomy to unload the compartment. Same thing for the ACL. We wouldn't put a meniscus in someone that has absolutely no ACL. We would reconstruct the ACL at the same time. Sometimes people have a small laxity of the ACL, and just by putting a meniscus, because we are putting this new stabilizer in the knee will feel more stable. But if the patient is totally ACL deficient, we would also perform an ACL reconstruction at the same time or in a staged fashion. Contraindication, obviously asymptomatic patient. We're not yet doing the surgery in a preventive manner. So someone who's asymptomatic, we tell them to avoid high impact activities, but to stay fit and active. And if they come to have more symptoms, then we can consider surgery. But if they're asymptomatics, we wouldn't do it. Inflammatory arthritis, obviously, because it would destroy the graft by the inflammatory process and lead to osteoarthritis or inflammatory degenerative arthritis quite rapidly. Significant osteoarthritis, just like you see on the picture, if we see a grade 3 or grade 4 narrowing of the joint line, we have passed the window where a meniscal transplant would be useful. And the last one, if a patient wants to continue to perform in competitive, high impact or pivoting sports, this is somewhat of a relative contraindication because of the shortage of grafts and as well as the cost of this type of surgery, we have to think about how patient will take care of their graft and how they will do in the long term. There are some people in Europe performing this type of surgery for professional soccer players, but we are not there yet because the risk of re-injury and re-tearing is so high that we have to reserve these type of procedure for people who will take care of it for the long term and avoid re-injuring it. So what's the process to have this surgery? Well, first we would have a referral, and we would perform a clinical and radiological assessment of the potential candidate. If there's no clear, if the history of either subtotal meniscectomy is not totally clear, or we don't have MRI to prove that it is meniscus deficient, sometimes we have to proceed with a diagnostic arthroscopy to confirm that the compartment is meniscus deficient. And sometimes we can help just by trimming if there's some meniscal flap remaining. Sometimes we can help symptoms and see how patients do after that. Patients will have a templating X-ray with a sizing sphere, just like you saw earlier, and a 3-foot standing X-ray to assess alignment. And this is to do the graft matching and to see if we need to do an osteotomy at the same time. And then we look at the size of a recipient, size of the potential donor and the different tissue banks. And if we have a match, we order the graft and surgery is booked. Surgical steps. At Banff Sport Medicine, we perform these surgeries with 2 orthopedic surgeons, as well as a surgical assistant and the nursing team. So there's a lot of people, but there is some tasks for everyone. And at some point of the surgery, you need a couple pairs of hands, and it's good to do these surgeries with at least 2 surgeons. So first of all, the first surgeon will perform the diagnostic arthroscopy. We will confirm the indication first, and then assess the articular surface in the affected compartment. As I said, we tolerate up to a grade 1 or 2, but wouldn't like to have diffuse grade 3 or 4 arthritis of the compartment. As you can see in the picture here, this is a patient that we recently operated on, only had a really small rim of residual meniscus. So that was a good candidate. And then we assess the other compartments of the knee, looking for any other meniscal injury or chondral injury, and obviously assess the ACL to make sure that the ACL is functional. The second surgeon will be assigned to preparing the graft. So on the back table, we will prepare the allograft. Different technique for the medial and lateral that we like to use. For the medial meniscus, we like to use bone plugs for the roots. So where the meniscus attaches to the bone, we keep a little plug of bone on the anterior and the posterior root, and then we pass sutures in the bone and at the meniscal junction and back down the bone, and that will help anchor the roots to the tibial plateau. For the lateral meniscus, because it is more closed shape and there's less distance between the 2 roots, we can do what we call a bone bridge technique. So we leave both of the root attached to the same bridge of bone. And with the special instrumentation, we drill a bone slot in the tibial plateau, and we can slide the meniscus in. So just for general information, this is the 2 different techniques we use. Now we prepare the compartment. So we want to remove the meniscus remnant, but leave a little rim to be able to sew the meniscus to the rim on the periphery. And with different instruments, a muncher and a shaver, we remove this remnant, and we like to create a little bleeding surface. So you can see on the right picture, there's a bit of bleeding along the rim, and this is good because we want to have some blood and healing cells to come in and heal the new meniscal graft to the capsule and the rim. We then drill the root tunnels or the bone slot, as I was saying. On top here, you can see that we have drilled the posterior root tunnel, and then we have an instrument with a passing suture that we retrieve at the front of the knee. We then perform a posteromedial and posterolateral or posterolateral approach, depending on which side it is. And this is an open approach that we do to retrieve the sutures that we're going to pass from inside to outside of the knee to sew the new meniscal graft to the capsule. And then we have two leading sutures that we pass at the junction of the meniscal body and the posterior horn. And this is to help to guide the meniscus graft, the meniscal graft inside the compartment. And then this is the fun part of surgery. When the graft comes in, we do a mini arthrotomy and we deliver the new graft. This is a P marked on the graft to say that it's the posterior horn, and also to mark which is the top of the meniscus, because when we prepare the graft, sometimes it can become confusing what is top and what is bottom of the meniscus. So that's why we make a mark with a marker. So meniscus is put inside the compartment. Here we can see that on the middle picture that the posterior root, the bone plug is well seated inside the tunnel. And we add some sutures at the back to fix it. And then we add some sutures all along on the vertical mattress fashion and what we call over surface and under surface, so over and under the meniscus to balance it. And we retrieve those sutures through our open approach on the posteromedial aspect. And this is the final result. So the meniscus is sewn in the compartment, and it's in good position, and we're quite happy with this transplant. There was a good size match between the donor and the recipient. So this is the final result with a brand new meniscus put in the compartment. Let's talk about rehabilitation. I'm sure this is important for most of us. I think that there's a lot of physiotherapists in the audience. So this is the rehabilitation program you can find on our website. So it's divided into 4 phases. And the first week is really a rest week. We put the patient in a brace, hinge brace, but that is locked in extension. And why we lock the brace is we want the root to kind of heal a little bit and just sit in their socket and allow some early healing. And it's really a week of rest, ice, elevation, compression, really basic post-op. And for about 6 weeks, we ask the patient to just do some featherweight bearing. And this is to let the root heal in their socket. Because if there's early weight bearing, the meniscus will get extruded and it will prevent the healing of the roots. By week 2, the patient can unlock the brace, and we allow motion up to 90 degrees till the 6th week. And this is to prevent some extra pressure or constraint on the sutures. So really to let the meniscus heal, because we know that in deeper flexion, there's lots of strain on the meniscus. So we don't want that in the early healing phase. We can perform some isometric quadriceps contraction. We want to get the muscle firing for the next phase. So the phase 2 is from week 6 to 12 and will allow patient to start some progressive weight bearing. So they will gradually wean their crutches when they're fully weight bearing, and then also gradually wean the brace when their muscles are stronger. At this point, we can allow flexion up to 120 degrees, and we can start some double leg quad strengthening, and also add some hamstring, glutes, and core strengthening. If patient at this point, they can hop onto a stationary bike and get some cardiovascular as well as aerobic exercise. By week 12, we can start the phase 3, and this is up to 6 months post-op. So this is really to focus on muscle bulk, muscle control. We can start adding some balance and proprioception exercises. We allow full range of motion of the knee. We can start to add some more dynamic strengthening exercises. We can start some single leg strengthening, but we want to avoid impact and pivoting. So we encourage patients to just perform low impact aerobic activities, walking, cycling, elliptical, swimming. These are all good activities they can do up to 6 months. Then by 6 to 12 months plus, this is the phase 4. We're trying to maximize the strength and starting some agility exercises. We want to add some more dynamic exercises. Let's say with a Bosu ball, we can start some single leg hop and jump, and gradual return to low impact activities. Usually from 6 to 12 months, we like to keep everything straight line. And if people want to recreationally get back to some pivoting activities, like downhill skiing, that would be more around a year post-op. What are the results of this type of procedure? We have to understand that most of the studies published in the literature are small case series. So there's a big heterogeneity of patient surgical technique, rehab protocol, what patient reported outcome are used. So results are difficult to compare or to pull in. However, there was a systematic review done 2 years ago for long-term survivorship and long-term outcome at minimum of 10 years. And they have shown a survivorship at 10 years of 73% and 60% at 15 years. So survivorship was defined as patient free of either a total meniscectomy or a repeat meniscal transplant or a conversion to either unicompartmental or total knee arthroplasty. There was, however, a significant improvement in patient-reported outcome from preoperative that was lasting up to 10 years. However, the results at 10 years were categorized as fair. So it's still an improvement, but these patients don't have a normal function. However, 90% of patients would say they would have the surgery again, so that's always a good sign. But there was still a 30% reoperation rate, and the main reason was a meniscal tear. So we know that even if we put that nice new allograft that will heal, this tissue is still more prone to re-tearing than a native meniscus. Let's talk about our experience at Banff Sport Medicine. So these are my 4 preceptors who I work with, Dr. Heemstra, Dr. Hurd, Dr. Butchko, and Dr. Kopka. So they have started the program in 2015, and then only a few patients per year, and were having that type of surgery. But since 2015 now, 44 patients have had a meniscal allograft transplant, and we have done 10 in the past 9 months, and we're hoping to do about 15 by the end of my fellowship year, which is at the end of June. So the program really have ramped up, and we're seeing more patients who are good candidates, and we have a good access to Graft. So this is one of probably the biggest program in Canada. We are now actively collecting prospective data on all our patients having this surgery, hoping to publish our results in the next few years. These are my references, and I'd like to thank you for joining. Thank you for listening. I hope this was interesting for all of you. This has been really a great year learning this surgery here with the group, and I hope to bring back this technique back to Montreal. Feel free to ask any question. I would love to hear what you guys have for questions, and we can have a discussion. That would be great.
Thank you, Alexi. We actually have one question already in the chat. So maybe why don't I start there, and then while everyone else is thinking of their excellent questions. So the question in the chat is, are the coronary ligaments important to meniscal function?
So I'm not sure if the coronary ligaments referred as the meniscofemoral ligaments. They are important to the meniscal function. It's not something that we reconstruct during the surgery, because I think that would make the procedure a lot more complex. I think some surgeons have tried to reconstruct either the intermeniscal ligament or the meniscofemoral ligament. It's not clear if this is if this is contributing to better results. So it's not something that we do routinely.
Oh, hi, Fabian team. Good to see you guys. Yeah, feel free if you do have a question. You should be able to turn on your mic, or just pop it in the chat too if you want.
Whoa.
Oh. We're wondering if any stem cell involvement would have a role in meniscal transplant, or if you're using stem cells in collaboration with this at all?
That's a good question. We are not. Stem cell therapy, from what I know, there's nothing approved in Canada to be used as official stem cell therapy for any indication. However, we know that when we drill the bone tunnels, so the root tunnels, we're creating some bleeding inside the knee. So we are bringing some healing cells and some healing factors inside the knee, and this is in some way what is contributing to the healing of the meniscus inside the compartment. But at the moment, there's no stem cell therapy that is added to this procedure. Has anyone seen a patient with meniscal transplant in their clinic or in rehab? Yeah, I see a raised hand. Do you want to share your experience, how they did, or what were the challenges?
Really bad. Yeah, we had one patient who unfortunately it didn't go very well, because afterwards she had a few of the contraindications. She was diagnosed as well with RA, rheumatoid arthritis, and she also had grade 3 chondromalacia of her femoral condyle. And she was a patient who also had an osteotomy prior to the meniscal transplant.
Okay.
So she actually rejected the meniscal transplant, and it had to be removed by arthroscopy, I believe. Correct? Is that how it?
Yeah, she had the HTO after the meniscal transplant. I think the meniscus was what started it all, but
yeah,
the tissue went necrotic and she rejected it.
Yeah. Well, she, as you said, she had many different reasons to fail, unfortunately. And I think it is key, patient selection. And it's also important to tell patient that, with every new procedure, people research it, on the internet, and they come into you and say, oh, I had a meniscectomy, I need a meniscal transplant. Well, it's really not everyone who will benefit, and patient selection is really the key. And also, I think patient expectations, right? It's not to have these people back in competitive sport. It's just to live like a healthy lifestyle with low impact activity. So I think that's also really important to have the expectations clear with patient.
So the first complication after the meniscal transplant is she actually got arthropfibrosis of the joint. So then she had to undergo a manipulation under anesthetic with cortisone shot, which seemed to help but she had to do that twice as well. So are you seeing that complication often too in arthrofibrotic joint?
Yeah, I didn't go over the complications of surgery, but I think I should have in retrospective. Arthrofibrosis is probably the #1 complication. The risk of infection, bleeding, blood clots is pretty small, but it's a fairly big surgery. We do a mini open arthrotomy. There is a lot going on. It's a fairly long procedure too. So arthrofibrosis is probably the #1 early complication that we see. And, the one I've seen this year and the 10 that we've done, only one has needed a manipulation and a rescope. And it's also a patient that had a osteochondral transplant at the same time, plus an osteotomy. So it was a big surgery. And we know that, every time we're adding more and more surgery, the risk of stiffness and arthrofibrosis is increased. But it's definitely something we see. And that's why we want, minimize the immobilization period. And after a week or sometimes 2, we want to get the patient moving, but it's definitely something that is quite frequent.
Yeah.
And why is the process for rehab so much significantly longer than most meniscus repairs with you're pivoting and I guess higher impact loading waiting until 6 months to a year?
Yeah, that's a good question. We know that by microscopic studies in animal studies that it takes about a year for the meniscus to, even there are not a lot of cells, that the host cells will infiltrate the new meniscus and start producing some collagen and some extracellular matrix. So it takes a year for the meniscus to be able to, the meniscus don't have a big healing and regeneration potential, but the cells are always producing collagen and extracellular matrix. So it takes that time for that meniscus to really become the host meniscus, the recipient meniscus, and not just a piece of tissue inside the knee. And also because the surface of healing is the whole meniscus, right? It's the root, it's the whole periphery. And also because just of how big the surgery is, we're slower at first, so it takes more time overall. But that's a really good question. Thanks.
We have another kind of general question, maybe a bit to kind of everyone, I guess, or more the other physios, from Jan in the chat, where she's asking, she's worked with M.A.T. patients early post-op, around 6 months, and she's just wondering whether anyone in the group had some ideas about what the common barriers were for patients in early rehab compared to, let's say, other MPFL or ACL patients. So she's kind of looking at any specific tips for success, if anyone had any to share.
I can tell my input first when we see them in clinic. I would say some things that we have chatted about already, but they're definitely more stiff than ACL and MPFL patients. So usually also because we restrict them, but we aim usually at 90 degrees at 6 weeks, but most of them, will be maybe towards 70, 80 degrees. So they're definitely more stiff. And also just the weight bearing, right? Being in crutches for 6 weeks versus an ACL patient or MPFL patient weight bearing right away. They are just slower initially. But if any physiotherapist wants to jump in and see what they have seen in the early phases, that would be a great input.
As I said, I've only seen the one, but I felt like that low rhythmic continual range of motion on the bike, back and forth, not cycling, but just using that as a tool at the beginning was really helpful for her. Just constant low load movement, complete repetitive, just to address those stiffness issues was really helpful, as opposed to usually don't need to do that with ACL and just regular meniscal stuff or MPFLs. Would be my only tip.
Yeah, that's a great tip. Thanks.
Any other burning questions while we have Alexi as a captive audience? Not a captive, but
Considering we're doing meniscal transplants in the knee, is there any research into like a labral transplant of the hip or anything? Is there any things going that direction?
It actually already exists, so they call it labrum reconstruction, and there are actually lots of studies going on about, you know, what is superior. Is it a labral repair? Is it a labral reconstruction to reconstruct the whole seal of the hip? Really not my specialty. I haven't seen any, but it's something already going on. It's a little bit different, you know, the labrum than the meniscus in terms of function, but the principle is similar. They're usually putting either a semitendinosus autograft or allograft, so just a tendon that is sewn around the acetabular rim to reconstruct the labrum and recreate that seal. So it's something already that is already done. Yeah. All right. Thanks for the questions, guys.
yeah, thanks for the great questions, and thanks again, Dr. Rousseau-Saine, for joining us tonight, and everyone else for joining us tonight. We hope to see you all again soon.
Thank you. Thanks for joining.
Thank you.
Well, thanks, Julianne, for organizing this and making this possible.
Yeah, no, thank you very much for agreeing. It was excellent presentation.
Thank you. Thank you, and send me the link whenever it's posted.
Oh, definitely. Yeah, everyone will get the link.
Okay,
I'll send
awesome.
it out for sure.
Is there one more question? Can you take one more?
Yeah, for sure. Yeah.
I was just wondering if there's anything coming down the pipe for like plugging the osteochondral lesion. If you have like, other than a transplant, is there anything being developed like to recreate that surface or that barrier?
You know what? I think it's the gold rush, right? It's the company that will find something to replace cartilage will be rich. There are different products. We already have different products available to kind of fill these defects, and they're all mostly kind of extracellular matrix. We have some products which is juvenile cartilage, so cartilage from babies and child that is chopped into small cubes that we can fill defects in. There is no great study showing that one product is superior to another, and sometimes we use these products. I don't think anything will come up that will, you know, replace totally cartilage, but we do see good results with these types of kind of fillers, if I may say, that can obviously not, they're not acting as normal cartilage, but they can help fill the gap and take some load just as normal cartilage. So it already exists. There are really different products available on the market, and we sometimes use them. But it has to be a contained lesion, so something that will not just, you know, leak out. So, you know, same thing, patient selection is the key.
Great, thank you.
No problem.
Okay, thanks everyone again. Have a great night. Nice to see your faces.
Thanks, Julianne. Take care.
Thanks.